our guest, welcome to our guest second time, Prof Natalie and Prof Brian, and we will start the first lectures today, which is the basic of non-invasive therapy by Prof Natalie. Welcome everybody, and we hope to success as yesterday, inshallah. Thank you.
Good morning, everyone. There was some of the conversation prior to starting that a lot of our chairpersons are wearing red. And in the USA, February is Heart Month for awareness for heart disease and congenital heart disease. And everybody wears red for that. So it was normal for us to have everybody wearing red. And it just so happens that Valentine's Day is in February too, but that wasn't the real reason. So we're going to expand this morning and go into non-invasive ventilation and all forms of it, where we talked predominantly about CPAP yesterday. So my conflicts of interests are essentially the same. Those that are important for this talk are for Philips Respironics. They make non-invasive masks, and I'm working with them on new development of several different masks and prongs in the pediatric population. So our outline for today is really to give us that definition of what is non-invasive ventilation and what all does it encompass, looking at some studies that are comparing non-invasive ventilation to CPAP, whether we synchronize or not when we're doing non-invasive ventilation, does it really matter, and the challenges that we really have with implementing non-invasive ventilation. So to start out, non-invasive ventilation is an overall umbrella term, and it includes anything that's higher than regular nasal cannula support. And for an infant, that's generally higher than 2 liters of oxygen. So high flow nasal cannula, even though we're unsure, still with the research, how much pressure and how much benefit you're really getting, depending on the disease process and the size of the patient, is included in that list. So high flow nasal cannula, CPAP, BiPAP, or full support of non-invasive ventilation, what we call the full settings. And our goals are the same, regardless of which support that we're using, which level of support. We want to maintain our FRC, recruit our collapsed alveoli, reduce work of breathing, and stimulate breathing or eliminate apneas. So they're the same goals that we had with CPAP that we talked about yesterday. We're just now including the list of all of our options to use for therapy in today's talk. And all of the goals are still that spiral effect. If we can maintain FRC, then we're helping to get to all of our other goals and recruit the alveoli and reduce work of breathing. This is a great schematic picture of what the options are and when we start which part, and how there's a lot of overlap in the therapy. So we'll start with just general oxygen therapy, which could be the nasal cannula, it can be a hood, a mask, but then there's a little bit of overlap with high flow nasal cannula therapy when we're heating and humidifying and giving much higher flows than we normally would. And then there's quite a bit of overlap as well with CPAP therapy for the evidence, when you would use it, and it's really that clinical judgment of the providers that are doing the ordering and the application as to what they feel is going to work best for that patient, because everybody's a little bit different, and it lets you really guide the therapy for that patient. There's a smaller amount of overlap between CPAP and BiPAP. You either need that extra support or you don't in most cases. And then that overlap that we've talked about quite a bit yesterday with bi-level or BiPAP and mechanical ventilation, where you could intubate, but you're doing full support via non-invasive ventilation, and really, where's the mark? When is the best time frame to intubate, kind of admit defeat, as we said yesterday, and where's that limit? And we don't really know where that limit is yet, so there's quite a bit of overlap in that population as well. So starting with high flow nasal cannula, a lot of people use this and think of this as a less invasive way to provide some pressure to the airways. And there's been several studies that have shown there's a very inconsistent level of pressure that's delivered according to liter flow and depending on the size of the population. And our real goals of high flow nasal cannula is to flush the dead space of the upper airway, the nasal, oral, and pharyngeal cavities of end expiratory gas with each breath. So we're making sure that all the other trace gases that we breathe in are gone and flushed out of the airway. And this makes for more efficient oxygen delivery if it doesn't have competing space for all the other gases, nitrogen, CO2, everything else that we're generally breathing in other than oxygen. And it provides that reservoir in your upper airway of that fresh oxygen gas constantly. So when they take a deep breath, they don't have to breathe through all of the trace gases that are in their upper airway. It's all oxygen and fresh gas of oxygen. And this really also can assist with their inspiratory demand. It gives them that little bit of oomph with each breath that kind of helps, but not necessarily as much as CPAP or non-invasive support. So it's kind of that in between. So it can really help decrease work of breathing a little bit depending on how high the flow is that you use. It also, for some patients, can provide what we call PEP therapy, and it's positive expiratory pressure. So they're breathing against, as we discussed yesterday, with the different types of CPAP, there's that work that comes in breathing against flow when you're breathing out and you're exhaling. And that is what we call PEP therapy. And there's different devices that we use predominantly in the adult population and older pediatrics where you're blowing against a resistor, and that is helping to keep your lungs and pop open alveoli and keep them from collapsing. So it's not really the same as PEEP, but it's blowing against that resistor that helps prevent the closing from occurring. And that is what we feel kind of happens a little bit with PEP, and which is why they're with high flow nasal cannula therapy, and that is why you don't really see an actual pressure reading when we do a lot of the different studies that have looked at that. The maximum that we've seen with a lot of the reports in the studies is 6 centimeters of water pressure in the neonatal population, but the highest flows that have been studied to achieve that is 8 liters per minute. And sometimes maybe we need to go higher than that, but we haven't really, just like there's that fear of going to higher PEEP levels on the ventilator, it's our fear of going to higher flow rates with the high flow nasal cannula, and sometimes it's our own concerns and fears that stop the therapy from working as it's supposed to by us not reaching those limits. And it's really outside of a research range. We don't really know what the highest limit is safe to go to on high flow nasal cannula in an infant population. So definitely much more research needs to be done. Looking at CPAP and going through this briefly, as we talked a lot about it yesterday, it's mostly applied via nasal mask and prongs. It's a set level of end expiratory pressure to help maintain end lung volumes. You can increase the oxygen, or it's mostly used when you have increasing oxygen needs. It's there to help reduce the work of breathing and may increase the tidal volume depending on the disease process. If you're able to stent open airways that are collapsing, then you're able to increase the tidal volume that you're able to get to the patient simply by alleviating that obstruction. Non-invasive positive pressure ventilation provides pretty much all of the modes you can use with invasive ventilation in a non-invasive form, meaning no endotracheal tube or no tracheostomy, doing it all via a mask or prongs. You can overcome work of breathing and distress for acute processes, and it's really meant to be used in a shorter term basis and not meant for very long-term therapy in infants as it is used for long-term therapy and sometimes adults in the pediatric population. And a lot of this has to do with the interfaces that we have available to us. Where those who make them are some of our ventilator companies, and they're in the ventilator business. They're not in the non-invasive mask business. So they make what they have to in order for us to use those modes, but they're really meant for short-term use. And we have the same challenges, and especially with non-invasive ventilation, more so than CPAP, because we tend to pull the prongs and the straps tighter because we're using higher pressures and 2 levels of pressure, and it pushes against the seals and creates those leaks more. And we really have to know when enough is enough, particularly when we have that big overlap that we saw in the picture between non-invasive ventilation and invasive ventilation, to know when we're doing harm and not good. And that's a line that we don't really know where that is yet, and a lot more research needs to be done. And it really needs to be individualized according to the patient and how they're doing with the non-invasive therapy. So some keys to success when using non-invasive therapy is really having skilled providers doing the application, knowing how to use the interfaces, how to apply them to infants and squirmy crying infants the best, without causing additional harm. A lot of the interfaces aren't supposed to be very tight. They're supposed to float on the face, and that changes according to the brand of the interface on how they were made. So applying one nasal mask isn't the same for every single nasal mask, particularly when you get into the pediatric population, because if it's something that's made to float on the face, the tighter you make it, the more leaks that you get. So it's really important to get that training from the individuals who are selling the masks, so you know exactly how this one was meant to be used. Also having very skilled assessments and troubleshooting to know when it's the patient versus when it's the equipment. And the people that apply it the most and really getting that volume of practice doing it is when you'll become more comfortable with it and really be able to pick up the little key pieces to help make it successful. Aggressive escalation of care, and really, again, knowing when we're hitting that point where we'll probably do less harm with the intubation, and really not worried so much about or going beyond what's going on with skin injury on the face, and if we're going too high on settings and we have too long of a leak. But the more that child gets in distress, it makes that intubation process much more risky, and you have much more of a risk of side effects during the intubation than you would if it was done in more of a controlled scenario when the child had a little bit more of a respiratory reserve. Which goes along with knowing when to admit defeat, which I feel like it's kind of my constant thing that I say, and I say it a lot to our doctors in the hospital. I think we need to admit defeat here and just intubate. And remembering that the infant is the #1 priority, and we have to do what's best for them and not necessarily what we think we want to do. And that's some of the hardest things, because we take it personal if they have to be intubated. But there may not have needed to be nothing that we could have done. It's just the disease process. So failure of therapy is really when you have oxygenation failure, depending on the age of your infant, what your oxygen saturation limits are that you're able to tolerate, and how much oxygen you want to deliver. If they have pulmonary hypertension, you might tolerate a higher oxygen level than you would otherwise for a preterm infant. But setting those guidelines and not really stretching them. If you set the guidelines in the beginning, don't say, well, it's okay, we can let the sats go a little bit lower. Just if we keep stretching them, then we're not doing the best thing for that infant. Ventilation failure is the same when we set those guidelines as to when we've hit ventilation failure with that disease process in that particular infant. Then we've hit that mark and we've hit that line. If we see a flat growth curve, if we're measuring and weighing the infants on a routine basis a couple times a week and really following that curve, if they're not growing, then they're spending too much of their energy and their calories simply breathing, and we need them to be able to grow. That's one of their main jobs as an infant is to grow. And if we're inhibiting them to be able to do that because we're not giving them, they're working too hard to breathe, and we need to give them more support. Inability to tolerate usual care. So if when the nurses are doing their care, changing diapers, changing linens, getting their vital signs, if on every single one of those instances you need to increase the oxygen level in order for them to tolerate it, they're not tolerating care. Or if they start to get more distress during that time frame, if they can't tolerate usual care, then they're also on the edge as well. And that is potentially another factor that there's a failure of therapy. How effective is non-invasive ventilation really? And there's a couple questions that we want to go through when looking at the literature, and hopefully that we can find those answers. One is one form of therapy better than another, particularly in specific instances? Are there modes that are more effective than others to use in non-invasive therapy? And what does the data really show on these? And unfortunately, there isn't a whole lot of information out there and a whole lot of studies that have been done on use of non-invasive therapy. When we look at nasal CPAP versus non-invasive positive pressure ventilation, there was a meta-analysis that was recently published in 2014 in the Cochrane database that really looked at extubation success with the use of non-invasive positive pressure ventilation versus nasal CPAP. And they saw that when using NIPPV, they saw a reduced reintubation rate within 48 hours to 1 week, and that's as far out as they really looked. There was no effect on chronic lung disease or mortality, and they felt potentially that synchronization could be beneficial, but this was through a meta-analysis, and it was really hard to really make that determination from that type of a review. This is the forest plot from that, and you can see that it barely meets extubation success. They said that there's extubation success, but inside that circle, that's where our marker is. It is almost on the line. So I don't know that we would really come to that conclusion that non-invasive positive pressure ventilation is more successful. It's really on the line, and it depends. And you really have a couple studies that are kind of swaying that because they had bigger numbers. And that's kind of the challenge with meta-analyses anyways, and we really need a better side-by-side trial. So there was a crossover study that was published in 2015 there, and this looked at 19 infants, and it was really looking only at short-term outcomes. It was a single-center study in Italy, and each patient received each therapy, NIPPV, synchronized NIPPV or SNPV, and nasal CPAP, and they received it for 4 hours each. And the first thing that I think about when reading the study is, how do you know if you hit success in 4 hours? Sometimes it takes longer than that. So I really worry about some of these crossover studies that are only giving therapy for a 4-hour time frame. But it's kind of one of the only ways to do some of these studies, as we talked about the variation in disease process that we give with the same diagnosis. It's hard to compare infants to each other. So what they saw was that synchronization appeared to be more effective in reducing desaturations, bradycardia, and apneas. But we really need some more long-term neurodevelopmental studies on this. They looked at very short-term outcomes, no long-term neurodevelopmental markers. And this is kind of what they saw. And both of these were statistically significant in reduction in desaturations and bradycardia, and desaturations below 80% overall. So more of a stabilization of heart rate and oxygen saturation, which is really what we want. One of the things that we talked about long-term for our neurodevelopmental outcomes is really maintaining a more steady state. It's the big swings of CO2 and O2 in the blood that causes a lot of the problems in the brain. So anything that we can use to really stabilize that process out should, in theory, be helpful neurodevelopmentally. There was a study that recently also came out that was just published in 2015. The numbers are really small on my screen for this one. I put that a little too small for me to be able to read. It was a crossover trial looking at non-invasive NAVA versus non-invasive pressure support. And it was randomized as to which mode was started, but the infants received both modes. They did a 10-minute stabilization period and then 5 minutes of recording of data. So their treatment time was only 15 minutes, which is much shorter than 4 hours before the crossover. And then they compared trigger delay, inspiratory times, and peak inspiratory pressure. So they didn't look at any of the other markers, which makes it a little bit more reasonable since it was only 15 minutes of treatment time, but it's still a very, very short treatment time. I kind of cut and pasted some of the results for this because the table was so large I couldn't get it onto a slide. But I picked out the important ones, the ones that were statistically significant, where they saw an improvement with synchrony, with non-invasive NAVA, overall, and these are all the markers that they use to help determine that. So, in summary, there isn't a lot of research out there for us to really know how to use non-invasive ventilation best. There are no recommendations for starting settings, for current disease processes, and some of the data that we have is very limited and very short treatment times, and definitely doesn't include any of those long-term outcomes that we really want to be seeing to know if it's helping neurodevelopmentally. As the one study showed us, there's no change in diagnosis of chronic lung disease or mortality, but that can't be our only markers that we're looking at in these populations. So we really need a lot more research. There are a lot of challenges for implementation that really might contribute to this. In some of the studies, in the meta-analyses, they used a wide variety of different types of machines that we know all function a little bit differently, and a wide variety of devices. There wasn't really a standardization of how to use an algorithm for use for the ventilation strategies, nor how to implement and put the interfaces on appropriately. So that is something that could really help. NAVA may assist with some of these interface challenges because you don't have to worry about the leak. The trigger doesn't come from up here. The trigger comes from the diaphragm. But there really is only one study at this point. We know there's quite a few centers that are using non-invasive NAVA, and they love it, and they have great success. There's just nothing really published out there on it for us to really follow. And then the question is, could there be a role for optimizing high-flow nasal cannula more? And if we look at studies on its intent of use to give more guidelines for use and upper limits and safety that might actually be more appropriate than people continuing to do studies to try to find what pressure level, when that's not what it was originally intended for. So we're kind of going beyond. We never got our true guidelines for the use, for what it was intended to use it for, and going beyond. And that kind of makes it a little bit trickier when trying to figure out how to use it appropriately. If there's any questions from anyone, I'd be happy to take those. You know, the difficult thing for a respiratory therapist is I can hear the ventilator alarming in the hallway, and it distracts me every time I hear it go off. I'm used to hearing a ventilator alarm and going, where's that coming from? Where's that coming from? And trying to go straight after it and fix it. Okay, great.